Welcome, everyone. Today we are very pleased to present someone who has spoken to us before and is a wonderful speaker and educator, and we've asked him to come back again. Dr. Eric Stratton received his Ph.D. in clinical psychology from the University of Nebraska and completed his predoctoral residency and postdoctoral training at University of Washington. He originally trained in psychological rehabilitation of schizophrenia and mental health law, but has shifted his primary research focus to psychoneuroimmunology. As part of his research, he has published papers showing that disclosure of HIV status has a positive impact on CD4 cell counts among HIV-positive psychiatric patients, and that high levels of psychological distress are associated with HSV2 genital lesions. He is currently working with Dr. Anna Wald on a twin study of the effects of personality and psychological distress on HSV1 oral lesions and viral shedding. At the UW Twin Registry, Dr. Stratton is studying the effects of caregiving on psychological distress, as well as the relationships among pro-inflammatory cytokines, depression, and pain. Dr. Stratton currently provides CBT for HIV-positive patients at the Madison Clinic, and in 2010 was awarded the Harborview Medical Center CARES Service Excellent Award for his work there. He plans to continue investigating the intersection of psychological states, physical health, and genetics. Dr. Stratton.
Thank you, Sharon. Okay, so let me begin by saying I'm trying a new presentation technology today that I'm sincerely hoping will not give anybody motion sickness, but we'll see how it goes. It's a Prezi, exactly. Psychology and the affiliated healthcare fields, that we continue to think about a more sort of comprehensive or holistic approach to people, taking more into consideration experience of. There must be something it is like to be a bat, I suppose. But what's that?
Battiness.
Battiness, exactly. You're very. But so we know that our consciousness is influenced by physical sensations, and so in the standard way that we think about science, it must indeed be the case then that our consciousness can affect our physical being as well. It's typically regarded as problematic scientifically if you believe that there is one physical system that impacts another system, but that there's no reciprocal relationship. And every time they've sort of looked at these kinds of things, for example, there was a period of time where people thought that gravity influenced matter, but it didn't seem like matter had any influence on gravity. Well, Einstein again sort of put that to rest. And so I think we're going to develop better understandings of the ways in which our consciousness and our attempts to manipulate our own consciousness can have impacts both positive and negative on our physical well-being. But let me start by getting a little bit less philosophical and a little bit more specific. Whoops, just went the wrong way. So if I'm claiming that there are reciprocal relationships between our brain, our mind, and the body, there must be ways in which stress gets under the skin. And so that raises the question, how is that possible? You don't need to read all this, but this is the beginning of the summary of it was an excellent, actually, review paper on psychoneuroimmunology and the ways in which stress influences the immune system by Suzanne Sagerstam and Greg Miller. And they talk about various ways in which, sympathetic fibers descending from the brain get into various tissue systems, and there are all sorts of ways, and we'll talk a little bit about cortisol as well, the ways in which the HPA axis, which is all the rage, ends up influencing our perceptions of stress and all those kinds of things. But there's this, so some of the ways in which we have in the research here at UW have conceptualized this, and Sharon mentioned it in the introduction, is psychological distress as potentially influencing infectious diseases. And this is, I'm not necessarily interested particularly in the dynamics of HSV infection, although Dr. Wald certainly is. But I'm interested in it as a model of understanding the ways in which stress can influence our physical functioning. And it's a good model because HSV infections, both type 1 and type 2, are very common. HSV1, for example, we're talking 60 to 100% of the population, depending on where you are in the world and how old you are. And so it's a very useful model. There's a tremendous amount of clinical heterogeneity in terms of symptoms. The most obvious of which are lesions, both oral lesions and genital lesions, but there are lots of people who have an HSV infection but never manifest any particular clinical symptoms except, and this is the great thing about working with Anna Wald and the group here at the University of Washington, is that they have a nice protocol whereby they get people to collect samples from the relevant mucosa in order to evaluate viral shedding, which is an important outcome because it increases, obviously, transmission risk if you're shedding virus, but you may not know about it because you're not clinically symptomatic. So, by luck, because I was actually still in college when they did this study, Anna and Deidre Buchwald and some other folks, while they were doing a clinical trial of acyclovir as a treatment for HSV2, for 22 weeks in a group of 19 women, they collected daily stress logs that were just visual analog scales. How stressed are you? Make a mark along this line from not stressed at all to as stressed as I could possibly imagine. They did that with stress, anxiety, and depression. In addition to collecting daily lesion diaries, in addition to collecting daily genital swabs for 120 days, roughly speaking. Is that right? 22 weeks? Whatever it is. 10 weeks in each arm of the study and 2 weeks of washout in between. This is a randomized, placebo-controlled crossover trial of acyclovir. And so they didn't do anything with these data, which I was happy to stumble into a couple of years ago. And after a lot of data crunching, we found that there wasn't a real linear relationship between stress and the HSV outcomes. But it definitely looked to be the case that once your stress sort of tipped over the level of about 6 out of 10, we started seeing relationships between distress and lesions. And we found it in a really sort of interesting and biologically plausible way. And so this graph, which is a little hard to understand, even if you've read the paper, but maybe certainly without it, but what it's basically showing you is, given that somebody had a lesion, right? So day 0 is the day of lesion onset. How likely were you to be in that high distress category versus the low distress category? Okay? And what we found across all 3 of the measures, and I only have 2 of them up here, stress, anxiety, and depression, is that about 5 or 6 days prior to lesion onset, if you are ultimately going to develop a lesion, it is much more likely, 5 to 10 times more likely that you are in that high distress group compared to the low distress group. Now, this is an interesting finding for us biologically because that 5 days is about the amount of time that it takes for the virus to travel from where it's latently infecting your sacral ganglia to the genital surface, right? So that's about what you would expect would be required in order for for a lesion to become manifest. So that was a really interesting and somewhat unexpected finding, because it could have gone the other way, right? It could have been breakdown in immunity at the mucosal surface. There was no reason that it would have to be at the site of latent infection. The nice thing about it appearing there, though, is that a lot of the animal models have shown that it's breakdown in the CD8 cells, which protect us against the latent infection and decrease of the efficiency of the remaining CD8 cells that seems to be associated with the stress-moderated relationship with clinical symptoms. So it definitely seems as if there's something about distress that is associated with these kind of infectious disease outcomes, but it raises a question, and a question that I take very seriously and that I'm not convinced we know the answer to yet, which is it possible that our experience, our phenomenology of stress, which we attribute maybe to certain things in our life, or maybe we can't attribute it to anything at all, we're sort of confused about why we're distressed, is it possible that it's actually the activation of our immune system, the activation of those cytokines that is actually sort of causing the stress in a certain sense? And so we didn't have an incredibly powerful way to look at that in this study, but we did have this, because you'll recall this is a crossover trial of acyclovir. It was statistically and clinically significant in terms of the use of acyclovir to reduce the distress, to reduce lesions, to reduce viral shedding. And so we thought, well, maybe we'll be able to detect a difference in the levels of stress, anxiety, and depression based on treatment condition, right? So you're thinking if your immune system is less activated because you're successfully controlling your virus, maybe you'll experience less distress. We did not actually find that. You can see that these stress, anxiety, and depression box plots all look identical whether you were in the placebo condition or the acyclovir condition. Again, I don't think this rules out the idea that the release of inflammatory cytokines or changes in our immune system may be at least a common pathway to reports of stress and depression, but we didn't detect it in this study particularly. So some of the other research that we're doing that I think is important is on caregiver research, which is how I've come across more of the work of Peter Vitaliano, who's also here in the department. And the great thing about Peter is that he, I think, has done a better job at sort of describing what he considers stress to be than a lot of people. So if we were to go back, which I won't do because, again, I don't want to make anybody sick. If we were to go back to that Segerstrom and Miller article, they talk about, the stress gets under the skin because the brain sends signals to the body, right? That all seems right. The problem is, what do you mean by stress? Right? How do you define stress? How would somebody in the audience define stress? Go ahead, give me your best objective definition of stress, your best operationalization. Because I promise you it will be as good as there exists in the literature. What is stress? Anything that perturbs homeostasis, right? Except there are lots of things, and that's right. I mean, that's the kind of definition that you hear. But there are lots of times where our homeostasis is disturbed, and people do not attribute it, do not consider it to be a stressor, right? And so the nice thing about Peter Vitaliano's definition is that he basically, and he says exposure to stress here. I would just say exposure to an event in your life, right? Multiplied by vulnerability, I guess, to psychological distress, which he conceptualizes both genetically and through common familial pathways. Divided by the number of resources that you have at your disposal to deploy is going to be strongly associated with your health habits, with your psychological distress, and ultimately physiological responses, illness, and mortality. So I think it's important to think about this definition of distress because it gets a number of key features, right? There are exposures, there are vulnerabilities that we have, which may be rooted in our common familial experiences. We grew up in a household that was stressed or depressed, genetic exposures, all these kinds of things. But even if we grew up in a stressful household or a genetically predisposed household, and we are experiencing an event that we are attributing stress to, we may have sufficient resources to overcome that distress, right? It may be the case that we're just ready for it, we were expecting this, it's a little stressful, but we can overcome. the other thing to keep in mind, I think, in this research is that a lot of research in psychoimmunology has been done on acute stressors. And there's no question that acute stressors have acute effects. And if we were to get really sort of into the literature, you'd find that the kinds of immune-mediated responses to stress that you find acutely are also the ones that you would expect to find when somebody is engaging in their fight or flight response, right? Sort of makes sense that the immune system shifts its focus a little bit in anticipation of being injured, of being wounded, those kinds of things. And so you see all this proliferation of our innate immunity in the peripheral blood. It's all good because if we get cut, we want our body to be able to handle it right away. And on the whole, acute stress doesn't really seem to be the driver of any of these effects on psychiatric and psychological well-being that we'll talk about. It seems like acute stress, once it's handled, your body returns to homeostasis, and you're all set to go. It's really the chronic stress that we're going to talk about that seems to be an impact. And chronic stress is interesting as well because, we think of chronic stress as really sort of predominantly an environmental exposure, but this is the wonderful thing about working in a twin registry and learning about all the twin research is basically everything is heritable, right? Although, of course, we're trying to look for heritability of interstitial cystitis in the twin registry, and it's not showing up very well. But other than pelvic pain, apparently, pretty much everything is heritable. Your personality is heritable, your intelligence is heritable, your optimism is heritable. Not exclusively, right? We're talking typically sort of more in the 30 to 40% of the variability is explained by underlying genetics. But it sort of raises the question that we'll talk about a little bit more about how confounded is the relationship between our exposure to stressors and our response to stressors, because there seems to be some sense in which these things are tied at a genetic level. And so I want to show you some caregiving data. We haven't published these yet. We're in the final phases of writing up the manuscript. Don't worry about, again, trying to strain yourself to see these results, but I'm going to talk about them in just a second. But before I do, let me talk generally about the use of twins in trying to uncover some of the relationships that might be confounding what you think is a causal relationship between, for example, caregiving and psychological distress. So the lovely thing that twins offer you the opportunity to do is control within the dizygotic twin pairs for common familial exposures, right? Dizygotic twins grew up at the same time, same age, in the same household, and so you can account imperfectly, but better than most, for those kinds of common environmental exposures. And so the difference that you see, and again, the way that you do the research is you start off, you always, whenever you're doing twin research, trying to figure out how much the relationship is due to common environment and genetics, you want to make sure that there's a relationship, right? There should be an overall phenotypic association, as we talk about. And so you start off, you just run your regression equations, you get your measure of caregiving, your measures of distress, you run a regression equation that accounts, obviously, for the relatedness of the twins, but you're not really looking at twinness yet. You just want to see, is there a relationship, okay? And so that's the overall phenotypic association, and that's what's going to be in the left-hand bars of all these charts. And so then you stratify these, your results by zygosity. So now you're trying to control for familial exposures, you're trying to control for genetics. And if you see a decrement from the overall phenotype, right, to the dizygotic twin phenotype, that suggests that there's some common familial exposure that is accounting for that much of the relationship that you see in the overall phenotypic effect. And then if you see an additional decrement from the DZ twins, from the dizygotic twins, the fraternal twins, down to the MZ twins, where now you're controlling for both familial exposures, and genetics, then you can start to infer from your data that there is a genetic contribution to both phenotypes, right? To both caregiving, for example, and psychological distress. So that's the model. That's the way that these data are interpreted. There's lots of other wonky stuff that I won't go into, but I have never seen lovelier data than we found for the caregiving stuff. I mean, it is really lovely. So these are data from the University of Washington Twin Registry. We asked about 1,000 twin pairs between 2006 and 2008 about their caregiver status, and also about psychological distress as measured by the SF8, the short form 8, mental component summary score, as measured by items from the BSI, the anxiety items there, from the perceived stress scale, and the PHQ-2 depression screener. And you see some really interesting and I think fairly clear patterns from the data. So in all cases, we found the association that you would expect with caregiving. Caregiving was associated with increases in anxiety, perceived stress, depression, and lower functioning on the SF8 scores. Very significant, no problem whatsoever in detecting that. But when you start stratifying by zygosity and looking at the within-pair effects, in other words, if you're discordant for caregiving, does that predict the difference between you and your co-twin in your depression score, whatever it might be, in your anxiety score and all that kind of stuff? And you see these really lovely results suggesting that there's certainly some familial contributions, which is what Peter would expect. He thinks that it's that vulnerability, if you think back to his model. It's not just the exposure, but it's your vulnerability to a distressful response, I guess, that sets the stage. And so obviously the family that you grew up in is going to be one of those potential vulnerabilities or one of those potential protective factors. But there definitely seems to be some genetics going on too. In other words, and this is sort of hard to interpret conceptually, but there's this idea that you are sort of both familially and genetically predisposed both to ending up as a caregiver at some point in your life, which again makes sense for some. If you think about the sort of wear and tear on our bodies that are associated with personality types, with exposures like that, and you're obviously getting your genetics from common sources in your family. So there's the common familial stuff, but also the genetic effects, and it seems to be so. You see the mental health functioning. There's obviously a pretty strong familial component to that. Some genetics. The anxiety. Not as much of an association within the families and the genetics, but I thought the perceived stress thing was really interesting because to the extent that these two things are both reduced equally, it's basically saying it's not necessarily genetics that's driving this relationship, but the perception of stress obviously seems to be something that is a function of your family of origin, right? I mean, most of the overall association seems to be accounted for by essentially how you were raised, I suppose. And it's also the PHQ-2 depression. The depression thing also looks, these are not made-up data, I swear, even though it looks so lovely. It really looks like the caregiving and depression things, and people are talking about all the things that we need to do for caregivers in order to prevent depression. Well, these data would suggest that's going to be a pretty hard task because there seems to be a really strong familial and genetic thing that is driving both your eventual exposure to being a caregiver and your depression. And I know it sounds funny to talk about how life events can be heritable, but this is a pretty robust finding. You know, when you do the research in personality, particularly, personality seems to be the factor that drives the heritability of life events. That people who are relatively more open to experience have life experiences that you would expect for people who are open to experience, and people who are not open to experience do not have those experiences, right? Or people who are emotionally unstable, what used to be called neurotic, they have different life experiences compared to people who are more emotionally stable. All right. So we have some sense then of how stress gets under the skin. There are certainly things in our brain that project into our body. There may be genetic components that are driving both relationships. And so one of the things that's taken a primary place in psychoneuroimmunology is inflammation. And it's not just psychoneuroimmunology, right? It's everywhere. It's cardiovascular disease, it's multiple sclerosis. Inflammation seems to be a really important component of lots of physical and mental health conditions, syndromes, and obviously every component of every healthy diet these days seems to have potent anti-inflammatory effects. But there's pretty much no question at this point that inflammation is depressing, that inflammation may be part of a common pathway to the ultimate development of depression, but it's in a particular way because inflammation causes sickness behaviors, right? That seems to be the strongest finding so far. So this is a review by Robert Dancer in Nature Reviews, where he sort of lays this whole thing out. I'm not going to go into excruciating detail of it, although I will come back to one of the charts that I think is interesting from it. But there are definitely there's obviously a general enough scientific interest in this that first of all they could get a review published in Nature Reviews, but there seems to be enough stuff. So it's not just that inflammation may contribute to the kinds of depression that we are seeing in, for example, an outpatient psychiatry clinic, but when people are receiving treatment for hepatitis C, right, they're getting interferon, treatment. That seems to be associated with the development of depression among people who do not have a history of depression up to that point. Well, let me take that back. It seems to be directly related to the interferon treatment, which has implications for the cytokine system. There are treatment implications for the understanding that there is an inflammatory pathway for depression. People talking about development of novel antidepressants based on the inflammatory findings. There seems to be reasonable evidence that the depression that we're talking about as a function of inflammation is similar to the depression in medically healthy individuals. This study was a little equivocal, I guess, in its results. What they really found was that, I'm sorry, I'll come back to that later. So there does seem to be, there was a subset of the people who got interferon treatment who developed depression, and there was a difference, or there was a similarity between those folks who had sort of interferon-related depression and people who were medically healthy who had depression. But there, of course, were half the people who got interferon treatment who didn't get depressed as a consequence of the treatment. So there's still some explanations to do there. And there's still some controversy into what comes first, the inflammation or the depression. Now, this particular study found that if you take a look at people who are medically and psychiatrically, psychologically healthy, you don't see necessarily increases in inflammation among those people, but once they get depressed, you start to see greater inflammatory markers when you do the assays in the blood. But there are some other folks who have found that the inflammation seems to come first. So what are we talking about? Well, this sickness behaviors that are characteristic of the cold or flu, you can all identify them, tend to be related to the actions of interleukin-1. I said beta, but alpha and beta both, interleukin-6 and TNF-alpha. These generate sickness behaviors. They seem to be associated with depressive episodes. And importantly, they seem to be associated with dysregulation of cortisol. And again, this is important because cortisol is anti-inflammatory, right? It's actually one of the most potent anti-inflammatories that we have endogenously. And it's been a very consistent finding, again, in psychoneuroimmunology research, that depression is associated with hypercortisolemia, with excessive cortisol activity. And so it raises this question, how could depression simultaneously be associated with both lots of cortisol and lots of inflammation? And it seems like in the long term, again, we're talking about chronic, right? These are the key components, the chronic exposure to stress, to inflammation. It seems like the pro-inflammatory cytokines might have some pathway by which they dysregulate our cortisol. They decrease our glucocorticoid receptor sensitivity, all these kinds of things that have long-term effects. And there seems to be some effect on current antidepressant treatments on improving glucocorticoid receptor sensitivity. But again, I don't think anybody, whether you are just a hardline biological psychiatrist or a touchy-feely complementary psychologist, who would say that we're loving the effects and the results that we're getting on the whole from antidepressant medication. So there's still a lot of work to be done. This is an interesting talk to do after Bill Banks gave his very interesting presentation on the blood-brain barrier, because it's not as if cytokines just freely flow between our periphery and our brain. And so there's this question of how is it that these pro-inflammatory cytokines that are activated as a consequence of our brain sort of projecting into our body and causing the release of cytokines, how can that then feed back into the brain? And I won't go into all the details as to how that might happen, because I don't think a lot of them are not understood. But we can definitely identify a number of mechanisms by which peripheral activation of pro-inflammatory cytokines ends up being mirrored in the brain. Right? There are pathways by which the cytokines either cross the blood-brain barrier or they activate the vagus nerves, and they end up influencing the cytokine levels in the brain. So there's this mirror of our peripheral activity in the central nervous system. So this is going back to Dancer's Nature review, and this is a model that I think is very interesting. And maybe self-evident at this point, but you see this, and he's talking specifically about the way in which systemic infections might influence the subsequent development of depression, but it could also be chronic stress, right, which has the same kind of pro-inflammatory consequences. You get these peripheral cytokine activation, you get the mirroring in the brain, changes in neuronal functioning that initiate sickness behaviors. which is you're not eating, your energy metabolism is different, you have decreased reward centers, your social and physical activity is decreasing, all these kinds of things that we tend to associate with depression. But then I love, there's this purple box that says risk factors for mood disorders that lead to decompensation in clinical depression. In other words, that risk factors box is what distinguishes people who have a pro-inflammatory event without depression from those who have a pro-inflammatory event with depression. And it sort of reminded me of this cartoon that I'm sure a bunch of you have seen, that there's some step missing here, right? So he's reading the chalkboard, all this complicated math. Then a miracle occurs in the middle, and we sort of assume, and I feel like there's a little bit of a similarity with that purple box, right? The risk factors appear, people decompensate into clinical depression. So the other thing that I think is not adequately addressed in this model is the role of emotional symptoms, because this is what we tend to think of as depression, right? Although we have neurovegetative symptoms, depression is primarily defined, especially if you look in the DSM, right? You have to have a depressed mood, or at least anhedonia, which I suppose could come about in terms of the vegetative symptoms. But can we find the effects of pro-inflammatory cytokines on emotions? And the answer to that is generally there have been some studies, particularly endotoxin studies, where you volunteer and you get stuck with an endotoxin. It's not enough to generate sickness behaviors. But I've seen at least one study in which they've shown emotional changes as a consequence of the injection of endotoxin and the subsequent pro-inflammatory cascade. But we didn't find it. So again, I'm not challenging you to try and read this poster, but we did a twin study where we were looking at the effects of various psychological stressors on pro-inflammatory cytokines, and we found so if you look at the meta-analyses of pro-inflammatory cytokine stuff, IL-1 doesn't seem to be a really robust finding in terms of pro-inflammation and depression. IL-6 and TNF-alpha seem to be more relevant, and we found the expected effect, at least in TNF-alpha, in the twins. It's about 105 twin pairs, male and female, about evenly divided between MZ and DZ twins. Medically healthy came in for a study on innate immune responding for some folks over in pulmonary medicine. We found the overall association that didn't seem to be terribly attenuated when we did our within-pair associations. So it suggests that maybe there is a genuine causal relationship between inflammation and decreases in physical vitality. But we didn't see anything with emotional symptoms. We didn't see any effect of the inflammation on changes in mood. And we had several measures in terms of stress. We had the Kessler 10-item depression scale, which has some nice psychometric properties. The SF8, again, we just didn't see much in terms of emotional symptoms, and so I think there's still a lot to be understood about how the emotional and the physical things come together. But perhaps more important than that is once we put BMI into these models, this effect was really significantly attenuated, right? So the inflammatory association that we saw between the association that we saw between inflammation and physical vitality was really significantly attenuated when we put BMI in the model, which makes sense because one of the things that we're really starting to understand is that our belly fat especially, although I suppose not just belly fat, but all of our adipose tissue is an endocrine organ, right, in ways that we did not necessarily think of for a long time. So it has properties, our adipose tissue has properties that seem to have regulatory effects on our endocrine system. And it also seems to be the case that the relationship is, you can have lean adipose tissue, and you can have, what's the opposite of lean adipose tissue? Fat adipose tissue. And it's that, it's the excessive fat that really seems to be contributing to inflammation in depression. So there are some important implications there. And it also seems to have an effect also on acute stress responding. This study found that women with greater abdominal adiposity had a greater stress response in terms of pro-inflammatory cytokines compared to those who were relatively lean. And so, again, the lean and obese, I suppose that should be it. The lean adipose tissue is different in a number of ways than obese adipose tissue. So you go from one to the other via a high-fat diet, and suddenly you see all these macrophages starting to appear in the obese adipose tissue. They're releasing all of these pro-inflammatory cytokines that we're seeing that are associated with depression. IL-6, TNF-alpha, MCP-1. MCP-1 is also another thing that we found to be a pretty good biomarker of subsequent development of cardiovascular, not we have found, has been found, in cardiovascular disease. Although, again, cardiovascular disease seems to be another one of those things where it's almost like everything seems to be associated with it in some way. And so I think, again, this starts when we think about Cartesian disorders, one where we're trying to say it's mind or it's body, or its brain or whatever. I mean, I think we need to start thinking a lot more about the ways in which all of these systems are interconnected, and how the subsequent development of depression may be related to the kinds of high-fat diets that we're taking in. These may be things that we want to think about as clinicians. How much work are we doing with our patients on stemming the tide, the pro-inflammatory tide, or whatever tides might be, in terms of the foods that people are eating, the physical activity that they're getting, and so on and so forth. Physical activity is another great example where there seems to be an acute pro-inflammatory response, obviously, as your muscles are rebuilding, but in the long term it seems to really decrease inflammation and do good things for us. So there are then, I think, a number of sensible associations that we can find between mind, brain, and body. There are many others. These are the ones I think that are on the top of my mind right now, but people are obviously doing the same work in PTSD. People are doing this work in schizophrenia. All the dysregulation of downstream neurotransmitter systems after a pro-inflammatory cascade. I mean, there's just lots of interesting stuff going on. But I am, notwithstanding the announcement, which apparently awarded me an honorary MD, for which I am extremely grateful. I'm a psychologist and got into psychology primarily because I am interested in our phenomenological experiences. Right? I'm interested in how the world shows up for us, and there are a lot of things there are a lot of things that are unexplained in biology. There are a lot of things that are unexplained in psychology, and some of these are the problems of consciousness. Now, there's an easy problem of consciousness, which is easy only in the relative sense. And the easy problems of consciousness are computational or neural tasks, right? We're trying to understand what are the structures of the brain, what are the related functions of those structures, and what is the consequence, I guess, of turning these things on and off. So computational neural tasks include, categorizing, reacting to the environment, integrating information, even reporting mental states, right? You can program a computer, for example, to tell you what the temperature is, right? And if it knows what the temperature is, you could probably program that same computer to tell you, I feel cold, right? Now, it doesn't actually have a phenomenal experience of feeling cold, but you could program it to do that, right? So you could report that quote-unquote mental state as a consequence of having the right input and output devices, and even deliberate control of behavior, right? There's lots of our behavior that is controlled by non-conscious processes, and some of these things, whether it be an involuntary reflex response or there's been a lot of talk lately in the wake of the whole Penn State scandal about the bystander effect, right? The relatively robust psychological finding where people sort of diffuse their responsibility to handle a situation, especially when you're in a context where there are lots of other people involved, right? Not my job to get involved. And so those are processes that are largely automatic, right? We don't think to ourselves. Well, we might think to ourselves consciously. There's lots of people involved. But when you do these studies and you try and really get down into it, people are not getting involved because of this sort of sentence in their head of there are lots of other people involved. So the easy problem of consciousness is easy because even though we don't have a complete understanding of it, we have a clear idea about how we might go about investigating these things, right? Anything from lesion studies in the brain to understand which systems do what, to straight up experimental psychology research and seeing how people respond under different situations, right? We have a pretty clear sense of how to do that. The hard problem of consciousness is what I've been talking about all along, which is how does the world show up for us, right? How is it that this mass of tissue in our heads and in our guts, right? I mean, think about, we talk about the complexity of the central nervous system. Think about how complicated it starts to get when you talk about the interplay between our gut microbiota, which have all sorts of potential motivational impacts on us, and our CNS system, all the different kinds of bacteria that are on our bodies, all these kinds of things that influence us. So we really have no clear idea how it is that the world shows up for us. And it's a valid question to ask, why don't our conscious processes take place in the dark, right? The easy problems of consciousness. Why are we not automatons? Why are we not zombies, to use one of the famous philosophy of science? It's conceivable, for example, to create a world in which everybody does everything exactly the same way that we do, except they have no conscious experience of any of it, right? You build a sufficiently sophisticated system that can respond to all the different kinds of behavioral inputs and outputs that we do. It looks beautiful. You could go up and have a conversation with another zombie and have no idea whether or not the person is conscious or not. And so it raises this question, why is there an experience of any of this stuff? Of what does our consciousness consist? And of course, an important question to me is, how much influence does it have? How much does our conscious experience of a situation influence our subsequent behavioral choices? Because there's, again, tons of research suggesting that non-conscious processes dominate a lot of our thinking and acting. And so I think one of the interesting research directions that people are taking is looking at the impacts of mindfulness meditation and other forms of meditation on both our physical systems and our behavioral choices. One of the mistakes I think that we make when we talk about the hard problem of consciousness, though, is imagining that there's some little mini us inside our heads who the information comes in from all of our sensory systems. It gets projected onto the big homuncular Cartesian theater, as Dan Dennett would call it. And the real us, who is inside our head somewhere, is seeing all this and making decisions. But of course, you see how this sort of reduces to the absurd, because then who's inside that little homunculus's head making decisions about what to do? And so, the clearest thing that we want to avoid is the notion that there is an us somewhere inside that is easily detectable, and that makes all of these decisions for us. And I think there is some of that implicit in the kind of work that we do in terms of mental health disorders, because we sort of think of it as these old mansions where you pull a rope in one room, and through a series of pulleys and wheels, it rings a bell and the butler comes, right? And if it's not working, you think you can go in there and maybe adjust one of those pulleys, and you're going to have the system work just fine again. And I think that's the approach that we often take in psychology and psychiatry, is if we just pull, if we adjust the right wheel or pull the right lever, we're going to get this problem fixed. And I think it's more complicated than that, especially when we take into account how all these systems are interconnected. But yeah, it's definitely, I think maybe in schizophrenia particularly, there's this idea of the information gets messed up somewhere on the way from the outside, or from the inside maybe, like to the homunculus, to the little us inside. And if we could just fix that, then the homunculus would not believe that he is Jesus. And I'm not talking about Tim Tebow. Although I would like to talk about Tim Tebow if anybody's interested. So mindfulness meditation, I think, is one of the interesting places where, it's sort of a deliberate manipulation of our conscious experience. The idea of mindfulness meditation is the attempt to sort of deliberately modify our conscious experience so as to actually exclude a lot of the noise that's going on inside our own head. There are lots of positive effects of this on psychological distress and cytokines. I just threw up a couple of examples. Mindfulness-based cognitive therapy. You see in the weightless control group not a lot of change over time, but in the mindfulness-based cognitive therapy group, you see real differences from time 1 to time 2 on, first of all, on mindfulness, which is what you would hope to find, but also on depression, symptom-focused rumination. There were some EEG results from this study as well. But it definitely seems like this deliberate attempt to engage in manipulation of our phenomenal experience, the reduction of the traffic of noise that goes on in our mind, seems to have some positive benefits for our physical health. You can also see it in terms of neuroendocrine and behavioral responses to psychosocial stress. Again, this is one of those funny studies. These graphs look lovely, but when you read the fine print, what you see is that although IL-6 in response to a social stress test was reduced in the high practice meditators, it was only reduced in the high practice meditators compared to the low practice meditators, and there were no difference with the control group. So more research, I guess, needed there. But you definitely see something is going on in terms of people. And there's beautiful studies. There's a guy at the University of Wisconsin, Richard Davidson, who through one of these unbelievably lucky, I guess, strokes of fate, has become friends with the Dalai Lama and has been doing a lot of research with very well practiced meditators, doing imaging studies and all this kind of stuff. Really cool stuff. If you haven't seen it, it's worth looking at. And so Davidson's doing a lot of research on what he calls the voluntary cultivation of compassion and the positive impacts that it has in terms of our minds and our bodies. But there's a problem, again, that we were talking about before with caregiving and these outcomes is it possible that our propensity to be a good meditator, to practice well, is associated with our pro-inflammatory cytokines, right? Is it possible that we are not practicing because the disruption that we feel as a consequence of this pro-inflammatory cascade is too distracting to us? And so obviously you need to do some research focused on people's dispositions towards mindfulness. And so this isn't a twin study, but we're hoping to do some more of the twin research where we can really kind of tease these things out. But the University of Washington is part of the national multidisciplinary approach to the study of chronic pelvic pain. We're one of the discovery sites. We've been asking all the people who come through healthy controls, positive controls for people who have chronic fatigue syndrome, but not chronic pelvic pain, and cases who have the MAP definition of chronic pelvic pain, about their dispositional mindfulness. In other words, without any intervention at all, are there differences? And the MAP has an interesting hypothesis that I think is actually not going to be, it's going to be disconfirmed, that people with chronic pelvic pain are going to look the same as people with other related chronic pain or fatigue symptoms. And we did not see that in our research on mindfulness. This is just an abstract that we sent to AUA for next year's meeting. But what we found actually is that the interstitial cystitis people look a lot more like the healthy controls than they do like the CFS patients. And that's sort of interesting to us, in part because some of the research that I've been doing with Brian Pershla is looking at chronic fatigue syndrome and the associations with psychological factors such as personality traits. And what we're seeing is that there seems to be some, again, sort of common genetic loading for emotional instability, neuroticism, which is really bad in terms of long-term mortality. Not really bad. It's a risk factor for all-cause mortality and cardiovascular disease. That is, neuroticism is. So again, let me explain how these graphs are working again just for a second. So if you see these changes between MZ and DZ twins, you start to wonder about whether there is a common genetic loading for the phenotypes, and that's exactly what we've found, again, working on the final phases of this paper with chronic fatigue syndrome. There seems to be something that is driving both emotional instability and chronic fatigue syndrome in the twins, such that you would not expect, it's not the case that sort of neuroticism causes chronic fatigue syndrome, but rather that they are both the result of an underlying genetic predisposition. And our favorite hypothesis is that being neurotic has a lot of wear and tear on your body. There's lots of research now going on leukocyte telomere lengths, which seem to be responsive to stress. And basically every time your cells divide, your telomeres get shorter, and they get shorter to a certain point, and they die, and that's bad. And your life is shorter to the extent that you have shorter telomeres. Those of you who were born with a father who was relatively old at conception have longer telomeres than the rest of us. So if you have an older father, you're in a relatively good situation. If not, sorry. So anyway, it's this sort of wear and tear. Again, these sort of psychological constructs, people think of CFS as maybe sort of a psychosomatic illness, and they think of personality as being largely a psychological feature, but there definitely seems to be something that is deep in our DNA, and that seems to be having an impact in terms of wear and tear on our bodies over time. So I guess in our search for non-Cartesian diseases and in our search for treatments for such, we've got a long way to go. I think a lot of what needs to happen is innovation in consciousness research, and one of the things that I think is sort of generally interesting is this idea that there are things that are real but not physical, and this is one of the conclusions that a philosopher named David Chalmers has come to, is that consciousness is a real entity. It's a fundamental entity like mass or energy, but it's not necessarily physical. So there are things that are real but not physical. For example, information is one thing that we know of that is a real entity. but it doesn't have any physical characteristics. And so maybe consciousness is the same thing. I don't know what that tells us about our likelihood of making any interesting discoveries about it. But some innovation in consciousness research, I think, is going to be important for a better comprehensive understanding of the two-way streets of psychoneuroimmunology. I think as clinicians, we want to think a lot more about whole person approaches, and I think the kinds of pressures I think that we feel as providers sort of argue against this, and it may be something that we want to be more conscientious about in terms of, we want to be able to spend enough time and have enough knowledge about enough subjects, or have people have access to enough things, enough interdisciplinary team conversations to make sure that somebody who's depressed is not just getting a pill and then leaving the clinic and going straight to McDonald's, right? Because that seems like two processes that are in opposition to each other, and things that we'd want to be working on more. And there are lots of ways to do that. But generally, I think the key is just mistrust of de facto dualism, of saying that you have a chemical imbalance, and if we can get that squared away, you're going to be fine. I mean, life is just more complicated than that, and I think not in sort of touchy-feely ways, but in sort of fundamentally important ways that we need to think about more in our research and in our clinical work. So that is it. Are there questions? Yes?
Given that there are probably a fairly large percentage of people who live a pretty unexamined emotional life, have there been studies that demonstrate that across the human spectrum everybody has consciousness? Or are there disorders where you don't have consciousness?
Right, that's a terrific question. And so in case there's anybody watching the stream, the idea is, and I'm going to restate the question a little bit and see if I've gotten it correct. Because one of the things, I mentioned Giovanni Tononi earlier, one of the things that he asked a question that I thought was really terrific, which is, what is it about consciousness, for example, that what we find is that people who have really severe damage or maybe complete lesioning of the cerebellum don't lose conscious experience, right? This is the locked-in phenomenon, right, where they are completely conscious in all the ways that we think of, and you can confirm this in various ways. Whereas, disruption of the corticostriatal areas of the brain have really fundamental impacts on consciousness, right? So I think there has been that kind of research about at least modifications of consciousness based on changes in brain structures, and we can see sort of tangible effects. In terms of whether there's been research done on whether there are people who do or don't have consciousness, I mean, there's certainly comparative research, right? The self-awareness research that's been done, for example, and the typical mechanism is, you get a bonobo or some other intelligent primate, and you paint a dot on its head, and you see if it goes up to a mirror, does it look at the object in the mirror and play with it because it's got this strange dot on its head, or does it go to its own head, right? And what you find among intelligent primates and dolphins and other creatures is that they will examine themselves. There's behaviors that they engage in that suggest that they recognize that what I am seeing is an image of myself. And so that suggests the kind of consciousness, at least, that we would think about in various ways. I'm not an expert on the research, but I just think it's interesting. But Tononi has this integrated information theory of consciousness, and he's using it, I think, in really interesting clinical ways to see if there are ways that we can detect the difference between coma, locked-in syndrome, and a vegetative state. And he's looking at the ways in which we can measure brain activity such that it seems to be organized information, which is what our brain does, versus disorganized information. And he uses the TMS method. They give them electromagnetic shocks to the head, and there are differences based on whether you're conscious or unconscious based on the sort of subsequent EEG readings that go on in the brain. So there's some of this stuff going on, but there's a long way to go.
Thank you, Eric.
Thank you.